let me just kick off. First of all, thank you, Keith, for that kind introduction. And thank you to Julie for her kind introduction to her house party. That's the best phrase I can think of for this. And Rahul for organizing this. I would like to thank the Canadian Institute of Health Research and the US NIH for having funded some of this work. Now, why can't, oh yeah. So first of all, let me point out that I have obviously got a potential for conflict of interest, and all of you must remember that and take or leave what I say with a pinch of salt. So I want to set the stage for what I'm really going to be talking about. I think by now, I suspect that most of you will be aware of the TOP trial. And I will certainly talk about that, but I want you to think about with me in a philosophical outline, why was neonatology so very slow at answering the question of when to transfuse preterm infants? And the leitmotif that will run through this talk is that basically we love physiology, animal and observational studies, and we shy away from doing randomized trials. There'll be a few evidence-based phrases that you may think of as we're walking through this. I may not mention them by name at various points, but we will sort of glide past issues to do with bias, surrogate outcomes, primary a priori outcome analyses, secondary outcomes, which are for hypothesis generation, and you'll see animal and human. So a more concrete outline of what I'm going to talk about is firstly about really to do with the risk-benefit ratio of transfusing for anemia. Then I will discuss some randomized trial data, and I'll try and use markers of internal validity and also ask the question, what external validity are there to buttress, say, the results of the TOP trial? And finally, I'm going to ask, what should we be concerned with now in terms of moving the field forward? So this is some very early work from the earliest days of neonatal intensive care, and a lot of it comes from Scandinavia. But if you draw your attention to the top here, can you see my pointer as I point?
Yes, we can see. Yeah.
Thanks. Okay. So in the top panel, the y-axis is hemoglobin in grams per deciliter, and here is postnatal age. And essentially, for the smallest infants, you can see that there's a 5th to a 95th centile range, and you can see that that makes it very difficult to decide a cutoff range. And authors pointed out themselves, rapid developmental changes prevent developing clear-cut criteria for transfusion, and consequently, clinical practices vary widely. You would have thought that that would have changed from the 1970s, but certainly by the time we were in the 2000s, we still hadn't changed really. And practices varied widely according to this quite comprehensive survey of European, North American physicians looking after babies less than 1,000 grams, who responded to the question, when will you transfuse an infant, with this sort of range. So again, on the y-axis is hemoglobin at which they would transfuse, and along the x-axis, anchored by no support right the way up to full mechanical ventilation. And depicted are the medians and interquartile ranges for week 1 down to week 4 of postnatal life. And you can see the point that's being made is that people were transfusing at quite differing ranges. And obviously that's because people were aware of the trade-off. So when a neonatologist comes to assess a baby, she will routinely consider that a higher hemoglobin may improve oxygen transport, cardiac output, weight gain, possibly anemia, but may also have a downside in terms of infections, necrotizing enterocolitis, death rates. And we're going to walk through some of that background because it puts into perspective why outcomes were chosen for various studies. So in terms of oxygenation, the advent of neuroscopy really was what led people to begin to think about measuring cerebral oxygen saturations. This is just one of many such data points. It comes from the group of Bos in Leiden, Holland. And essentially, this is not randomized data. This is observational data. And for each of 3 pre-transfusion hemoglobin ranges, which are depicted, there are 3 plots. Before the onset of a transfusion, during transfusion, and after a transfusion. And this panel is the regional cerebral oxygen saturation. And you can see that there's an immediate jump up for the babies who are being transfused by their clinicians for a hemoglobin below 9.7 grams per deciliter. And that jump up is not matched by the jump upwards in those being transfused at a slightly higher hemoglobin level. And naturally, this led some workers to assume that this would be of some benefit. A similar sort of physiological reasoning was undertaken, for example, in this study related to cardiac function. And here again, you can see that here clinicians were not asked to transfuse, but of their own volition, they chose to transfuse at cutoffs of now hematocrits, less than 21%, 20 to 26%, and greater than 27%. And in each of the various plots, you can see that if in fact they were being transfused at a much lower hematocrit, it appeared that their parameters on ultrasound measures, for example, stroke volume, were higher than the parameters of the babies being transfused at a higher hematocrit level. Again, this is not randomized data, this is observational data, but it led the authors and several others in the literature to argue that the heart was working harder, as it were, if the baby was allowed to go down to a lower hematocrit. But there's a side of a downside to transfusing, and it's exemplified in this picture. I don't know where people are from who are joining this, but in the US, it's certainly not the case that it's a free voluntary basis that drives people to donate blood. Often they're being paid for their blood. And of course, I'm quite sure that you're aware that this practice was associated in the earlier years, in the 1980s, with high unanticipated events of transmission of undesirable vectors, such as HIV. On the y-axis here is the risk of infection of unit being transfused. And it was as high as 1 in 100 of units in 1983. From the point that people began to recognize that HIV was a problem, of course, screening rapidly took place, and for hepatitis. And you can see that over the ensuing years, as more reliable testing was done, we were able collectively to drive down the transmission rates from units of blood to a far more acceptable range of about 1 in a million or 1 in 10 million. But that's for the bugs that we know about. Of course, you all know that such new vectors such as Nile Valley and Chagas disease and various other transmissible agents are constantly being found. So that's not the end of the story as regards infections. We're relatively safe, but we still have a ways to go. Then the issue of death was first identified in adult intensive care units, and then in pediatric ICU units. This is data from Holland, and for as a set probability of death on a predictive outcome using a POD score on the x-axis, at every probability of death, the black bars were the children who had received also a transfusion, and they would appear to have had a higher standardized mortality rate, as you can see on the y-axis. This was then extrapolated into our baby population. This is a large observational data set out of Brazil, and you can see on this diagram that on the x-axis is depicted the days of hospital stay, and on the y-axis, the cumulative hazard of death, which appears to be higher for transfused versus non-transfused infants. Now, this is obviously very alarming, but I'm sure that most of the audience has identified that the problem here is that this is associational data. And we were first warned about associations by Bill Silverman, perhaps the grandfather of evidence-based neonatology. And in this graph, you can find his book on retrolental fibroplasia at this website listed here. And in this diagram, you'll see that what he's mapped out is the event rates for retrolental fibroplasia, or ROP as we would call it, from the 40s through towards the 50s. And you can see the huge rise in the rate of RLF. But this is matched by a corresponding rise for vitamin therapy, oxygen therapy, and iron therapy. And I think everybody knows that the community was misled by iron as being the potential vector. As we now know, this was wrong, but this is one of the problems with an associational study. And we still have not really fully internalized some of the lessons, because we just need to look at what happened with the literature around necrotizing enterocolitis. On the left hand of this diagram, we've plotted here the observational studies, including something like 12,000 infants. And you can see that the cumulative plot for the odds ratio is out at 7.5, favoring restrictive approaches. In other words, withholding blood transfusion. On the other hand, a diametrically opposite viewpoint is put by the randomized studies, which are smaller. At this point, there were only about 600 babies, but the diamond, while crossing over equivalence, seemed to favor a liberal approach. It was in an exactly opposite direction. And this sort of brings up this paper, which is, I think, a very important paper that we haven't paid as much attention to in neonatology as perhaps we should. It contrasts the results of animal physiology studies and human clinical trials. There's only one infant or baby trial here, which is on antenatal corticosteroids. And you can see that there is a slight discrepancy in terms of the effects on mortality. But since that was published, the results of caffeine and the results of sustained inflation again bring into contrast the results from physiological experimental studies, whether in animals or, I would argue, in humans and human trials. And we need to think a little bit more about that. There are some general principles. I mean, I'm not saying that experimental practice such as physiology, etc., have no validity for us. They are essential for a sound biological basis. But for most questions of therapy, we really need RCTs and ideally replicated RCTs. So with that, let me move to what hemoglobin triggers could we use. And that does bring up a little bit of history with an Australian connection, because the first study that we really embarked on was the PINT study. And here is Chad Anderson out of Adelaide. I don't know if Chad's on, but certainly we'll be discussing some of his group's data at the end. But the PINT study was the only study until very recently that could contribute to an issue of what were the long-term effects of maintaining either high or low hemoglobin in preterm infants. And this is the data from the Cochrane that Robin White accumulated, and I've boxed in the starting point for the new generation of trials, which was a suggestion in a secondary analysis. I'll be emphasizing the point that this was a secondary analysis at one standard deviation of a cognitive delay in the Baileys, suggesting that a liberal approach to transfusion was better than a restrictive approach. The primary analysis was a composite outcome of a two standard deviation difference combined with cerebral palsy, visual impairment, hearing impairment, or any neurosensory impairment. And that failed to show any significant finding. So again, I want to emphasize that this was a post hoc secondary analysis. That left us with a lot of questions, and we really didn't know what was the right approach. And that's why with the Neonatal Research Network of the NICHD, we embarked on the TOP trial, the Transfusion of Prematures trial. And that trial was funded by both the NICHD, but also by the Blood Institute of the NIH. The peacock for that trial was in a population of less than 1,000-gram infants between 22 to 29 weeks gestation, was the randomized intervention of a high hemoglobin as compared to a low hemoglobin, leading to a difference in death or neurodisability by 22 to 26 months. This was an unblinded, pragmatic, randomized trial with two strata, center and birth weight, less than 750 grams and greater than 750 grams. We had two hemoglobin threshold algorithms, a high and a low, to trigger the transfusion. We did not mandate any blood sampling. It was, again, a pragmatic trial. The intervention was applied up to 36 weeks post-menstrual age or hospital discharge. The inclusion criteria were infants between 22 to 29 weeks and less than or equal to 1,000 grams birth weight. We wanted to apply the algorithm early on, so we enrolled these infants within 48 hours of postnatal age. We did not want to be allowing clinicians to transfuse these infants until they were randomized, and therefore we did not allow any transfusions unless they were emergent related to post-delivery issues in the first 6 hours of life. We obviously had various exclusion criteria, including whether the clinicians considered the baby to be non-viable, and obviously we needed to have informed consent. This was the algorithm that we randomized into, and it was very similar to the algorithm of the PINT trial, which you may have seen before. We asked, is the baby requiring respiratory support? And if yes, there was a randomization within high and low, which dropped in value in terms of a trigger for the transfusion from week 1 down to week 3. A corresponding algorithm was applied if the baby was not on respiratory support. The values for high triggers are in red, the values for low are in blue. The primary outcome was assessed by a blinded assessor. So although the maneuver itself was not blinded, the outcome assessment was blinded and was the primary outcome of death or a neurodevelopmental impairment, which consisted of any of a cognitive Bailey 3 less than 85, cerebral palsy in the moderate to severe range, a vision impairment, a bilateral hearing deficit that required amplification. With a standard alpha and beta, we needed 1,800 infants approximately. We duly enrolled that, followed them through. Obviously, there was a dropout with some deaths. We certainly had some loss to follow up, but in total, we were able to accrue 93% of the outcome data for all of the randomized infants, being either NDI or death by up to 2 years of age. These are the selected baseline characteristics, and they were reasonably well balanced between the high hemoglobin group and the low hemoglobin group. The stratification by birth weight seemed to be reasonably balanced as well. Corticosteroids in this era were correspondingly highly used. And we did succeed in enrolling early. So this is the age at randomization, and the initial hemoglobins were quite comparable between high and low. In terms of the maternal education, 40% in both groups were over high school. So did the randomization and the maneuver actually separate out a high and a low group? We were successful. You can see here, having started out at randomization, we got very quick separation, consisting of about 1.9 grams per deciliter, which was maintained throughout to the point of either discharge from the hospital unit or 36 weeks. This was the primary outcome. And as you can see, it was absolutely no different between high and low group. If we broke down the primary composite outcome between death at up to 2 years or NDI at 2-year assessment, again, there was no difference. As regards selected hospital outcomes, there's been quite a controversy in the literature. Some people arguing for reduction, some people arguing for an improvement in head ultrasound outcomes. We saw no difference. I've alluded already to the controversy about necrotizing enterocolitis. We saw no difference. Apnea, as you know, some have argued that apnea was improved by maintaining a higher hemoglobin. The date up to final use of caffeine, we again, being a pragmatic trial, we did not mandate this, but we saw no difference in the usage of caffeine by the clinicians. Retinopathy and bronchopulmonary dysplasia, again, there's been controversy in the literature, particularly about retinopathy. I think that our findings would suggest that the prior associations were an associational finding, but we found no difference between the groups on either retinopathy or BPD. We had a host of anthropometry outcomes. Again, no difference between the two groups. Obviously, the number of transfusions is here really being driven by the arm to which the baby was randomized to. So we would expect to find a difference, and that was duly the case. There were more transfusions in the high group. Interestingly, we didn't really find a difference in total donor exposure. We did notice that if we asked the question, was the baby ever transfused? Only 3% in the high group avoided a transfusion, whereas 12% avoided a transfusion in the low group. How strictly did our clinicians hold the line at the algorithm? We had repeated re-educations of the groups of clinicians, and my co-PI and myself looked at independently all non-algorithmic transfusions to adjudicate whether they were in violation. And you can see here in the last row that there were certainly more violations in the low transfusion group. I think this again just shows just how much clinicians are driven by the sense of wanting to keep a hemoglobin higher and tend to get wobbly or anxious at lower hemoglobins. Nonetheless, we do not find any reason to support that practice. Before we move on to leaving the randomized evaluation, I want to just sort of ask, is there any external validity to support the findings of the top trial? And perhaps the most important external validity is reproducibility. And you may know that the German group led by Axel Franz in Tübingen did a very similar trial over a very similar time period. And this was published in JAMA, the reference is here. And Axel has given me permission to show some of his slides. Their Peacock question was extremely similar to our Peacock questions, down to the primary outcome and when the primary outcome was assessed. Their hemoglobin ranges for intervention were expressed as hematocrit, but were essentially not any different from ours. And they did have a slight difference, which is the separation between the restrictive arm and the liberal arm. And perhaps the separation is not quite as good. There's a fair degree of overlap, as you can see. And Axel himself would accept that this is the case. He and I have talked about why we had a slightly different separation, even though our hematocrit ranges or hemoglobin ranges were very similar. And I think that in general, it may be the case that clinicians in Germany simply don't transfuse as much. We haven't quite sorted that out. Nonetheless, the primary endpoint really was no different. And the primary endpoint, as I've mentioned, was very similar to ours. So I think we have one criteria of external validity satisfied. We've certainly got reproducibility. Approaching the external validity question in a slightly different way, how does the comparison to the issue of use of erythropoietin sort of align with this? This was a nice meta-analysis done by the co-workers at the Charité Hospital in Berlin. And you can see this was done in 2017. And here is the various trials. And there's an interesting phenomenon The largest trial, this Chinese trial of about 600, seems to have the strongest effect size, quite different from the others. Now, this is a little bit odd. You generally tend to find, as you know, with a larger trial, that the effect size is actually smaller, in fact. And I pointed out in the comparison with NEC that if you find a very, very strong signal, and this is a very strong signal, this is the point estimate of an odds ratio of 0.3. Even the upper 95% confidence interval of about 0.6 is really quite strong. You have to wonder, is there something unusual about that trial? I mean, and this is perhaps buttressed by the results of a single larger trial of about 900 odd from Sandy Jewell. And you can see here that for the primary outcome of death or severe neurodevelopmental impairment, there was no benefit to erythropoietin versus placebo. Even when Sandra did a secondary analysis for now moderate to severe neurodevelopmental impairment, there didn't appear to be any difference. So I think we've put this issue about the hemoglobin range and longer term outcome reasonably satisfactorily to bed. And that brings me back to perhaps the most important slide from my vantage point to suggest might provide anchors for when to transfuse and when not to. So I wouldn't be moving towards the high target range. I would be moving towards the low target range. So obviously there may be other questions related to all of this. And I'm just going to pick on two, and perhaps the audience has other questions related to where the field might go. But the most immediate things that come to my mind are blood banking concerns. We have some data from TOP that we will likely be producing over the next while, but I want to point out simply that we don't look or think about enough the issues to do with how the blood is handled. So this is a scanning electron micrograph, and you know how beautiful it is. It's striking that normal red cells just are so symmetrical and very, I mean, it's a very attractive picture, isn't it? In contrast to this picture, now you'll notice that this is a black and white picture, so I have amplified the difference, but frankly, this was the only one I could find. So that's the reason why. But once you store red cells and keep them for a while, they lose that uniform shape, irregardless of what type of medium you use. Now in adult intensive care units, and particularly coronary intensive care units, people began to zero in on this aspect, and they began to ask, well, is there a relationship between adverse outcomes and the type of storage media, or old versus red cell, young red cells? And I don't know about your practices, but certainly I've been in hospitals where cardiac surgeons and cardiac anaesthetists would insist on having, quotes, fresh blood or young blood. That introduces quite a strain onto the system. A Canadian group out of Ottawa actually did a randomized trial, the RIPI trial, and randomized to receiving standard red blood cells, which ranged up to about a month of age, against fresh red blood cells, and their primary composite outcome was a combination of either necrotizing enterocolitis, moderate to severe IVH, surgically needing retinopathy of prematurity, or BPD, or death. Now that's quite a large composite outcome, but nonetheless, It's a trial of about 400 babies. There was no signal at all. But we've probably got a lot of other things to check out. And we haven't done those studies. I know that in Australia, there's likely to be some randomized trials shortly on how blood is handled. But right now, we don't really have too much data about this. Another aspect that I think is worth just very briefly talking about, I've been using the general notion of an overall target range. Can one individualize when an individual baby should be transfused? Workers in Glasgow in Britain quite some time back in the 70s had tried various ways of measuring available oxygen of blood, but it was a fairly tedious process which was done in an in vitro laboratory setup of blood taken from the infant. The advent of what I had shown you before from Holland about the neuroscopy measurements, near-infrared spectroscopy, which was obviously first put on the map, as we know, in University College Hospital, London, quite some time ago. Obviously, that finds a potential application here. I told you that I was skeptical about the physiological data. Here was an attempt to find a more clinically relevant outcome. This comes from the Adelaide group led by Chad Anderson. And it tries to look at the predictive accuracy of a combination of what they call CFTOE, in other words, cerebral fractional tissue oxygen extraction, and gestational age. And in this ROC curve, you can see that we're getting pretty close to a very good sensitivity and specificity. The only problem is this is introducing quite a few complications. Now, this is a cerebral diagram, by which I mean a highly intellectual diagram put forward by Chad and his group in 2015. And they've done a fair bit of work on this. But I think while it's very appealing physiologically, they'd be the first to accept that it needs to be demonstrably helpful at the bedside. You certainly need to have a measure of cardiac output, and you certainly need to have a measure of oxygen extraction derived from neuroscopy. So I think we're a bit of a way away still from that, although we might well get some pushback from the Adelaide group if they're on the line. And I would also say that the only test of neuroscopy so far has been by a European group led out of Copenhagen. And this really asks the question, if we randomize to the availability of NIRS or without NIRS, and the way they did this was to simply cover up the neuroscopy module so that the clinicians couldn't see it. And that's what they called the control as compared to the NIRS group. And their primary outcome when they did this was to look for where on oxygen cerebral saturations babies were peaking over a defined level that they adjudicated as being above 80, or had hypoxemia. Both, they argued, were detrimental, and this was the cutoff here. They combined the two events and made up a scale for burden of hypoxia and hyperoxia. I think that this was an excellent first attempt at getting some information in a randomized manner. And you can see that they were able to cut down the median duration of the so-called burden of hypoxia and hyperoxemia And that was statistically significantly different. For me, the proof of the pudding is in a non-surrogate outcome. And this was for all-cause mortality. And this is for cerebral ultrasound measurements, which were soundly non-significant. Of course, with the sample size of 80 per group, it's very likely that they're radically underpowered, and they themselves acknowledge that. The Copenhagen group are in the process of trying to do a much larger study across Europe, and I wish them much luck. I think it's a difficult study to do, but a very important study to do. And I think it might help to put this notion of how does hemoglobin and cerebral oxygen saturation interact in a more understandable framework. All this to simply say that I think we're a long way from individualizing at what hemoglobin threshold we should transfuse a baby. And with that, I'll conclude that in TOP, we found an approximately 2 grams per deciliter difference, which made no significant differences in the primary outcomes or secondary outcomes. I think it's safe to stay within the ranges of the TOP algorithm, preferring the lower range. So with that, I'll hand over back to Rahul and Key.
Yeah, thank you, Haresh. That's a very excellent presentation. Just say that I have particular interest in this topic because we are running the WIT trial, asking a different question. I spoke with Haresh before. We are doing withholding feed during blood transfusion or not. Interestingly, the question about the quality of blood, there was Australian New Zealand Intensive Care Society trial, the transfuse trial, doing the adult intensive care, found no difference with whether they are old or new blood. I can report to say that Michael Stark and Chet Anderson, the trial of watch cells, have just been funded to start. So I think they're already starting some working with 5 units already starting to do the trial. So we'll wait for that to see what's the quality of blood mean in the trial.
That's a very important question to ask, and I congratulate them.
Mm-hmm. Yeah. And let's see what are the questions we have.
Would you like to unmute yourself? Prof. Martin has a question.
Yeah. So I saw one question to say about what is the crossover in the 2 linear arm, whether the crossover. In fact, it's more Haresh already actually mentioned about the compliance. So the compliance is a bit more a problem in the low target arm. Do you think there's any difference, any influence that may muddy the water, or you think that? I don't think there is. Yeah.
So of course it muddies the water. It would be great if there was no compliance issues. What I would say, however, is that this was a pragmatic trial. It's very difficult, as anyone knows who's doing large trials, to get buy-in. And that means that you've got to make it at least reasonable. So it may be that a clinician has a slightly different perspective. However, if we look at it, that you need to involve the largest group of clinicians in order to get a pragmatic answer, I don't think we're going to get better than that. I think we've actually answered the question. Together with the Germans, we'll be probably doing a secondary analysis looking at only babies who have not been violating any compliance rule. But actually, I really don't think it's going to change the issue. But I think Martin had a question, didn't he? Hello, Martin.
Hello, Haresh. Thank you very much for that talk. Great summary of the issues, as always. And I'll ask the same question I usually ask you and Barbara, is that this question of the physiology moving into the randomised control trial and clinical trials, and then the problem that we have, that we may have not selected out specific physical subgroups into each of our arms, and we may have physiologically benefit or have physiological harm in one arm and also in the other arm. And I know you've addressed this to a degree at the beginning, which I think is really important, this fact that we can't just immediately translate animal physiology and other physiology into our human trials. But then when we face with where we're at now, I mean, there's two options. One is there is no difference in the transfusion set points for our babies, and that may well be true. And I think you're leaning more towards getting that conclusion now. The other result is that we're still not properly physiologically selecting babies for specific treatments. And I'm pleased to see that you did go a bit further in those last few slides to say, well, maybe there are some other physiological targets. And that was really my question. Can you see other physiological targets that might help us in selecting babies who will definitely benefit from a transfusion versus those who may not?
Martin, it's always lovely to hear your approach. And I knew as soon as you were going to ask a question that would be your question. So I fully understand. The first thing to say is I love physiology. And I'm not by any means a narrow-minded trialist, I think. I think it's very important to generate hypotheses. And we generate hypotheses through an understanding of a deep physiological matrix. And I think that your group has done outstanding work in laying the planks of some of that. The reason that I think the issue about individualization is so important is that it is, first of all, physiologically sound. Second, that there's some hypothesis generation that's been done, for example, by Chad's group, along the lines of non-surrogate outcomes. But the third thing is that the proof of the pudding is in the eating. And that has not been done here. The proof has not been provided. And yet I think this is low-hanging fruit. If you're going to provide a physiological explanation, that's fine. It works and it helps clinicians at the bedside understand what may be going on. But if from that you're going to draw a line in the sand and say this is how it shall be, that I wouldn't agree with. Sorry, long-winded answer, Martin.
No, I think and also a very fair answer, and I understand. I know that you have got both arms here, that you're interested in the physiology, and that's shown by the way you've structured your talk, which I think was really interesting. But I mean, as you know, it's a problem in many of our neonatal trials that we seem to be getting negative trials for benefits that initially we thought had some physiological rationale, and there were even trials that did prove this. So the question is it that adding more and more numbers of unselected babies, particularly, well, they're a little bit selected, as you point out, and this is another problem, is we do tend to enroll a group of babies who are available to us, but it's not necessarily all of the babies that might benefit. And that's a real issue for us as well, as how we get a more representative sample rather than just those ones who've been well looked after in hospital. I'm talking more about perinatal trials, I suppose, but it's a similar thing, that we've got this problem of not being able to enroll the whole group because we need to be pragmatic when we run an RCT as well.
Well, you know, I mean, I think lots of people have said this. I've certainly been one of those arguing for years now that we need to do larger trials. And what you just said reminded me that I hadn't addressed the issue of subgroups. Well, the only way you can address the issue of subgroups is by larger trials. And I know in Australia, you guys have had lots of preachers about big trials. Well, you know, I probably count myself as one of the preachers, but I think you just need bigger trials. I think the community of neonatologists and the community of pediatricians needs to get away from the notion, okay, we've done one trial and that ends the issue. There are always other questions to ask, and simply one should move on to the next trial. In fact, you know, Jerry Lucy basically went on for years about how every baby in a preterm nursery should be part of a trial. I actually, frankly, don't know any nursery that does that, not even the ones that I've worked at, by which I mean to say that at least I was energetic in asking that to happen. But even there, it didn't happen. It's tough.
Thank you, Haresh. No, I agree with all your comments. Thank you.
Yeah. And now there's one question, I don't know what, about in practically how long would you administer red blood cell transfusion, acute blood loss, severe hemorrhage? I think that probably not really into your trial is mainly in elective transfusion, isn't it?
Yeah, I mean, acute blood loss is a totally separate context. We're not challenging replacing an actively bleeding infant, if I've understood what you've asked. I can't see the written chat question.
Yeah. So maybe I just go back to a little bit I mentioned about the WIT trial or withholding feed trial, and asking us a different question. You have any thoughts about that? So I'm biased because I wanted that get trial done. And you have any the question about withholding feed? In your trial, there are some units are doing withholding feed. Is that correct?
Practice varied. I mean, this was a range of units across the US. It was a US only trial. You'll notice that the baseline event rate in both arms was about 10%. That's about double the baseline event rate that was happening in Germany. And I don't think that there's any systematic rationale to explain it. I mean, probiotics were being thrown around in some places in Germany, but not all. Some units were feeding, some units were not. For years now, while I was practicing, for years I was not particularly concerned about withholding feeds during blood transfusion. And I think we have sort of challenged adequately the association between blood transfusion and NEC, but that doesn't mean to say that the issue about feeding is irrelevant. We don't have randomized data about that.
Yeah, the interesting thing is your nicotizing enterocolitis rate between the two arms are identical, 10%. So whether you so of course the higher target had more transfusion.
Yeah. Yes, that's exactly right. So essentially, it's an indirect argument from what I would say is that there is no relationship to NEC. I mean, I've been arguing that for a long time. And I've been arguing that the proponents of so-called TRANEC need to demonstrate that actually in prospective studies, there is a true association. And I think the best of the observational studies was that by Ravi Patel,
exactly.
Where in fact, he very diligently looked for what was happening on a prospective sample and had a prior hypothesis. I mean, I think that what happened before was people were transfusing a lot. They then stopped transfusing. And as they stopped transfusing, the pendulum went so far that actually you got an underperfusion of the gut. And then you transfuse and you get a reperfusion injury. At least I think that that's what was happening. And I think Ravi Patel's prospective observational cohort seems to indicate a similar phenomenon.
I think Rafi's paper was published in JAMA. Unfortunately, not a lot of people, neonatologists may look for JAMA for this type of question. It was an elegant study. It was really, and it showed that in more likely to relate to anemia rather than the transfusion.
Correct.
So, but you, in your study, you show no difference with NEC.
Yes, but our target lower hemoglobin threshold that we had decided a long time ago from the PINT study was in fact just above where Ravi's lower threshold was.
Yeah, yeah. So you're not really testing that because you had based on Ravi's, which is in your group, who set up the lower target. It's still about what they worry about the association with NEC. Yeah. Any other question from, yeah, sorry. Sorry, Haresh, you want to add something?
No, that's fine.
Any questions? And it's been a fantastic talk. And I think if any question, you can leave off an email, and then we can take it from there. As I say, we not all the slides are available for distribution or for view, and so Haresh is going to prepare a set that is suitable for viewing online. Okay, thank you. So I think we are just about over time. So thank you, Haresh, and it's great to catch up.
Yes.
Yeah, been a long while. We know each other.
We look forward to meetings where we can be actually face to face instead of in this